So we will move on directly to our next speaker, and we're very happy to have Ray and Victoria and now Dr. David Fisman, who may need no introduction to any of you who've been following the news, but he is a professor in the Division of Epidemiology at the Dalai Lama School of Public Health. And there was a question earlier I can answer now, just as I introduced him, because part of U of T is looking at a center. Some of my colleagues that work on Occ disease prevention and the Occ illness committee, they're looking at a center, just let me get the name right, focused on Occ disease prevention. The name actually is to be determined, but it's a divisional initiative, so that might answer one of the earlier questions. And Dr. Fisman is a professor again of the epidemiology at this Dalai Lama School of Public Health at U of T. He has enjoyed a career in both infectious disease epidemiology and clinical medicine. Dr. Fisman is a physician epidemiologist with research interests that fall at the intersection of applied epidemiology, mathematical modeling, and applied health economics. So he's interested in developing and applying novel methodological tools that will allow physicians and public health experts to make the best possible decisions around communicable disease control using the best available data. Dr. Fisman completed a residency in internal medicine at McGill and Brown universities before completing a fellowship at the Beth Israel Deaconess Medical Center in Boston, and has an MPH at Harvard School of Public Health. He was also a HRQ Fellow in Health Policy between 1998 and 2001 at the Harvard Center for Risk Analysis. He's currently, as I said, a professor at U of T in the epidemiology, and he serves on Ontario's COVID science and modeling table and holds emergency COVID research funds from the Canadian Institute of Health Research. So welcome, Dr. Fisman.
So thank you so much for the opportunity to speak today and for the invitation, and thank you really to Kimberly and Alec and a number of people I see online from the Canadian Occ health community, because I've learned a tremendous amount from you over the last year and a half. So I was assigned a fairly nebulous title, I think, and I'll try to do my best. I've sort of, in trying to put a talk together, I thought, why don't we just do some terms of reference in terms of what we're talking about with the pandemic as of August 2021 in Canada. And then as we get into myths and roadblocks, I'd like to flip over and talk mostly about aerosol transmission and why we haven't done better in terms of addressing aerosol transmission in a variety of settings. And again, I'll try very hard to stick to time because I think the interactive part of this is probably the most important. So just to update everyone, these two slides are sort of a daily tracker smoothed out of global COVID cases and deaths. So global daily cases are on the left. Reported deaths are on the right. Just to walk through the slide, the blue curve represents smoothed daily reported COVID cases since April 2020. So this initially was a rather small epidemic in China. And then what you can see all the way over at the left-hand side of the left-hand figure is a little bump, which represents the initial emergence, wave 1 in North America and Western Europe of COVID. We sort of controlled that, but then went right into a Southern Hemisphere epidemic. And then you see last fall's COVID epidemic as the first big hump with sort of bunny ears on it, the blue curve with bunny ears. The bunny ears is just reduction in testing over Christmas time. Things sort of subsided after that. And then you see emergence of probably variants. The subsequent springtime wave was really the alpha variant and the various N501Y positive variants emerging worldwide. And now we're over on the right-hand side of that left-hand figure, and we're into a global wave that's being driven at least in part by the emergence of Delta. Down at the bottom of that same figure, the red curve is the daily estimated reproduction number for COVID. So if it's below 1, that means things decline. If it's above 1, it means that we're into exponential growth. And you can see that we really oscillate over at the left-hand side. When things first emerged, we had a reproduction number of about 3 in Canada and elsewhere. But then all the stuff we've been doing in terms of distancing and masking and testing, tracing, and isolating, that's all bringing the reproduction number of this disease down. And so, somewhat more recently with immunity from natural infection and vaccination. So we oscillate up and down around a reproduction number of 1. So this is really a game of inches. When we're below 1, the epidemic declines. And when we're above 1, even just a little bit above 1, the epidemic grows exponentially. What the toll is, to turn to the figure on the right-hand side, what the toll of all of this is really unclear. We're at 210 million counted cases and about 4.5 million counted global deaths at this point in the pandemic. But we know the deaths are an underestimate. And in fact, we're sort of going up and down around 10,000 people dying from this every day globally. That's clearly an underestimate. And what you see with that sort of jagged, almost vertical lines on the right-hand side of the right-hand curve is when Peru updated their death estimates. So they went back and audited their deaths, and they found that they'd underreported deaths by about 100,000. And so that's one country revising their deaths upward. That's what it did to sort of daily totals. And the estimate is, the economist estimated about 2 months ago that we're probably more like 13 million deaths. So we're really missing a lot of these. This has been a tremendous mortality event worldwide. This is what Canada looks like. These are cumulative epidemic curves as of this morning by province. And what you can see is, it's great to hear Nectaria talk about all the wonderful stuff that's happened in Quebec, because of course Quebec had the largest epidemic initially, but has also learned a lot and changed a lot. And it's been very impressive to see how the response changed in Quebec. And what you see is this crossing of the curves, where Ontario had a smaller epidemic, now has the largest epidemic in Canada by far. Quebec has really flattened out a lot. Light blue is Alberta, punching above its weight by population. I think Alberta's only 4 million people or so. Dark blue is British Columbia. Yellow and green are Saskatchewan and Manitoba. And then down at the bottom are the territories in the Atlantic provinces, which really have had remarkable success to date in terms of controlling this disease, showing that this can be controlled in the Canadian context. These are this morning's reproduction number estimates for across Canada. The COVID-6, as we call them, Alberta, BC, Manitoba, Saskatchewan, Quebec, Ontario, all have reproduction numbers now somewhere between 1.1 and 1.4. So they're all into exponential growth. This is the so-called wave 4. It's here in Canada. In the provinces that have done historically, and territories that have historically done a bit better, we see a mixed bag. So you see Newfoundland and Labrador, 0 cases, PEI, 0 cases. New Brunswick has started to struggle. They have a cluster in Moncton in unvaccinated young people, and that's starting to spiral and affect other regions in New Brunswick. And Nova Scotia's got 8 cases, with I think most of those are actually still in travelers. The big story, to my mind, in Canada right now is the Northern Territories. Most of that 60 cases, it's unclear what the breakdown is of those 60 cases. Most of them are Northwest Territories, which if we had done this talk last week would have had a 0. So we had a rather explosive outbreak in a little fly-in town called Fort Good Hope that's in the Satu region in the western part of the Northwest Territories. And that was at a social event, a hand games tournament. And of course, people went home from that hand games tournament to their towns and back to Yellowknife and Inuvik. And so all of those places now are dealing with COVID. So you've suddenly got this rapid emergence of COVID in the north, which is disastrous because I believe Yellowknife at this point has only 2 ICU beds. If you get a good going COVID outbreak, that's going to saturate very fast. And of course, people need to be medevaced south for care. So it's potentially quite a scary situation. Um, this is kind of a multi-wave model that I've been working on for COVID. It's actually worked quite well. I wanted to show you, if you ignore the the red and blue parts of this curve, this is Ontario. You can see a couple of waves here from last fall. I've cut off the first wave, but what you can see here is that we came through first wave. We had a much bigger, sorry, it came through a second wave in the fall, last fall, had actually a much bigger third wave due to emergence of the Alpha variant. We closed schools on April the 12th. Uh, and in terms of the contribution of schools, case counts fell like a rock thereafter. And we've actually had a fair bit of quiet in Ontario, but now things are starting to heat up, and the different colored lines. So the orange line is the model fit from I think that was July 17th. That was last fit. And then every week or so, I've been refitting the model, seeing what's happening. And you can see the purple to the blue to the red. There's this ongoing progressive change. Every time I refit the model, it gets more and more pessimistic about where we're going. So right now we're headed pretty much straight up in Ontario. Still not a lot of traffic to the ICUs, but that's because via vaccination and also via behavior, we have an epidemic that's increasingly concentrated in young people. So you can see this sort of, there's the very pale blue, the darker blue, the sort of medium blue, and then the dark blue at the bottom. The dark blue at the bottom is kids. This thing that's sort of expanding like a trumpet in the figure on the left, that's the share of cases coming from 20 to 40-year-olds, and it's going up and up, partly because of behavior, partly because they're under-vaccinated. And we can look at that in a different way as a heat map and see that percent positivity is also kind of going up in those age groups. We just published a paper about this week, looking at, I won't go through this in detail in view of the time, but looking at what happens if you adjust for undertesting. Young males are not only have disproportionately high test positivity, they're also the least likely to get tested. And if you adjust, we have a method where you can adjust for test frequency. This figure on the right-hand side of this figure shows what we think the true incidence was by age and sex in Ontario. And you can see an epidemic that's heavily driven by younger individuals. Um, as the CDC famously said in their leaked documents that came out in the Washington Post, the war has changed. That's because we've never really seen a variant like the Delta variant. The Indians did tell us this last spring, but there has been a tendency when other countries tell us things to ignore them until they happen here. What the figure on the left shows is strain replacement, initially with N501Y positive variants like alpha, beta, and gamma, going back to last March, where we got up to basically 100% of variants being N501Y positive in Ontario, total strain replacement. And then since that time, those have been replaced by N501Y negative variants, which is not a reversion to original wild type COVID, but is complete replacement by Delta. It looks as though, oh my gosh, I have an out of date reproduction number figure on the right hand side. So you can sort of imagine what we actually have right now is if we break this down by Delta and non-Delta, this holds for non-Delta and 501Y alpha, beta, gamma. In the top panel here, we're at around 0.7 today. In the bottom panel, this should actually show us at about 1.6. So we really have good going growth with the Delta variant. And that has important implications for herd immunity. Just a simple heuristic for the fraction you need to vaccinate to get to herd immunity is 1 minus 1 over R0. Well, if the original R0 was 2.5 or 3, we should have been able to get to herd immunity with 80 or 90% effective vaccines. We'd already be there, basically. The N501Y positive variants, of course, pushed up the basic reproduction number further. And now we're into Delta, which has effectively made herd immunity unattainable for the moment, even with 95% effective vaccines until we're able to vaccinate children. So herd immunity would be a situation where even if you do absolutely nothing, you have a reproduction number that's less than 1. And that's not attainable for us now with Delta. Okay. So just to turn to one of the real struggles, is so since we can't vaccinate our way out of this in the near term, I think the most likely um, uh, uh, the most likely course of events is this fall we are probably going to mop up remaining susceptibility in Canada, either via people being vaccinated or those who are unvaccinated are going to have some degree of immunity because they will inevitably get infected with a bug that has a reproduction number of 7 or 8. That's sort of getting into measles and chickenpox territory. So a lot of susceptibility will be mopped up this fall. So we probably do want to think about other things that we can do to slow spread. And in order to achieve that, we need to acknowledge how COVID is transmitted, which I think folks in occupational health have been way ahead of the curve on this. I remain mystified at a lot of my colleagues in clinical infectious disease and public health in terms of their reluctance to acknowledge how the information has changed over time in terms of how this spreads. This is an old slide. COVID is a weird disease, or SARS-2. It has a number of paradoxical features. We know it's associated with pre-symptomatic transmission, and indeed, fully 1/3 of people who are infected are completely asymptomatic based on best estimates. So, among the 2/3 who are symptomatic, a significant fraction of those folks will die, and the infection fatality ratio for this is around 1%. So that's the same as the 1918, 1919 flu, but a lot of people are also asymptomatic, and that's weird. We've also been confronted with a disease that has a lot of dead ends and also super spreader events. So there's this tremendous heterogeneity in the infectivity of the disease, which has puzzled people and confused people. And lastly, there's been these odd sort of early recognition by the Japanese is the transmission seems to happen only in certain contexts. They coined this idea of close, closed, and crowded settings or where COVID transmits. Now, all of these things, except heterogeneity of severity, pre-symptomatic transmission, asymptomatic transmission, overdispersion of R, and the closed, close, and crowded stuff, all strongly imply that this is an aerosol transmitted disease. I won't, in the interest of time, I won't dig down into this too much. On the left here, you have a contact tracing diagram from Singapore, where you can see lots of dead ends and then also lots of big clusters. The middle panel is Adam Kucharski's work showing that it's basically a coin toss. If you have a disease like this, you get it imported into the population. His bottom figure shows that the probability of having a large outbreak depends on the number of cases you introduce into the population, because each individual case is unlikely to set up an epidemic. But if you introduce cases repeatedly, eventually it's going to explode. And we see that in the right-hand figure from Ontario, where we had multiple cases introduced. Nothing happened, nothing happened, nothing happened, and then boom, all of a sudden we were into a full-blown epidemic in March 2020. The Japanese closed, close, and crowded is pretty easy to explain once you start to look at how aerosol is generated by infected people. That you have a 3 order of magnitude difference between breathing and sneezing in terms of the volume of aerosol that people generate. Paul Chen, who's a wonderful engineering student at U of T, also showed that you have over dispersion of viral load. And without walking through this figure in too much detail, what it's trying to show is that you you are likely to have high viral load in a small minority of individuals infected with COVID. So now you get into sort of a series of unfortunate events model for COVID, where these super spreader events are generated by individuals, the minority of individuals before the variants emerged. Viral load is much higher now, who have high viral load, are in poorly ventilated environments, closed, close, crowded environments, and excuse me, and are doing things with the respiratory tracts that generate aerosol. So singing, laughing, talking, shouting. So back to aerosol. This is just a beautiful schematic, I think, from Kim Prather with an assist from Christine Shea and Jennifer McDonald. looking at what this revised model of COVID transmission doesn't depend on sort of magical large droplets or close contact looks like. We've seen a number of large outbreaks, for example, in spinning studios. We can have a pre-symptomatic index case who's got high viral load before symptoms onset. They can be shouting because they're a spinning instructor. They're going to create droplet spray at short range that's going to infect people potentially ballistically. But those large particles are going to be far outnumbered by small aerosol particles that infect people via inhalation. You can also have buoyant aerosols that hang in the environment and can be infectious, we know, for up to at least 3 hours. The Van Dormelen experiment was stopped at hour 3, and the viral particles in the air were still infectious, so probably longer than 3 hours. And how long they hang is going to depend on how well ventilated the space is. Indeed, we were able to publish this sort of opinion piece in Lancet this past spring on the 10 different reasons why we clearly have dominant aerosol transmission of COVID. And I suspect that all these lines of evidence are well known to those on the call, and I won't walk through them individually. But what's happened since we've published this is the evidence for aerosol transmission has only really grown stronger. And indeed, we have proof of concept now. This is a marvelous paper from Mark Ferris and colleagues at Cambridge University, looking at the COVID and the non-COVID wards in their National Health Services hospitals, and finding that with regular testing, because remember, a lot of people are asymptomatic, the relative risk of COVID on the COVID wards and the healthcare workers was 47 times higher than the risk of COVID on the non-COVID wards in green. The folks in green have the same incidence of COVID as the general population. The folks in red on the COVID wards are much higher. They change over to FFP3 masks, and all of a sudden, incidence in the two groups equalizes. We have proof of concept from schools as well. This is a CDC report from Georgia from last year, where dilution, which basically means open the windows, open the doors, reduces transmission in schools by about 40%. If they add in purification, which is portable HEPA units, you've got an additional reduction, 10% on top of that. Opening windows and doors and putting in HEPA air cleaners does nothing to large droplets that infect via ballistic transmission, and obviously does nothing to infection via close contact in schools. Doesn't change that, but you get these dramatic effects. In the same MMWR, of course, you have an additional 40% reduction with masks. So we have a lot of proof of concept at this point for, there's no reason to expect these dramatic effects if you didn't have dominant aerosol transmission. And remember, the reproduction number globally in that first slide I showed is oscillating up and down around 1. We just need to get it below 1. That's the tipping point. Once it's below 1, this goes away by itself. So having transmission is a big deal. This is another excellent article just from some Occ health experts and physicians in Australia looking at, the practicality of preventing COVID in healthcare is that you'd like to put people with an airborne transmitted disease in negative pressure rooms, but you don't have enough. So what do you do? And they sort of talk about how they've tried to sort of manage risk in that setting and have leaned fairly heavily on HEPA air cleaners. When I work in healthcare, I do some periodic infectious disease attending, and I work at 2 different hospitals. At both of those hospitals, there's a little area in the hospital where healthcare workers go to be unmasked and drink their coffee and chat with their friends. They're indoor spaces. I doubt they're particularly well ventilated. It's sort of, in both cases, they're auditorium. One's an auditorium, the other's by a library. And I just think how you can improve risk in those places just with simple things like HEPA air cleaners. And of course, there's practical guidance that comes out of this. This is Trish Greenhall's very nice schematic in terms of, what kind of activity are you engaged in? Is it indoors? Is it outdoors? Is it well ventilated, poorly ventilated? And what we see is with an overdispersed R, the very high reproduction number, at least pre-Delta, represented a weighted average of cases, the majority with a reproduction number less than one. Those are going to be dead ends, and a reproduction number much greater than one, which is the minority. And if you focus your efforts on the infective minority with ventilation, dedensification, masks, and appropriate respirators in high-risk settings, we should be able to tip the epidemic below one. What's frustrating for me is this is a figure I made last. I think this is about a year old now. Sort of talking about this, that we probably want to focus on high-risk places that we need to keep open, whether it's food processing, whether it's schools, and use the tools that we have in our toolbox to keep those places safe. The problem is you can't do this if you don't have acknowledgement by public health authorities of how this disease spreads. So why haven't we done this? Why haven't we embraced, this sort of, at this point, slap in the face, obvious evidence in terms of how this is being transmitted and what that implies for how we control it? I think there are a couple of things at play. One is disinformation. The disinformation environment around COVID is obviously, well beyond the scope of a single talk. But we have well-funded, well-organized disinformation related both to the severity of the disease, the use of masks, vaccine safety, and I think that disinformation is coming from some different sources and different actors. But it means that anything that we try to do to help is going to be swimming upstream against organized disinformation. There are, of course, the usual sort of challenges in health, where you can be talking about an intervention that is going to basically pay for itself at a societal level, but paying for that intervention up front is still going to come out of someone's budget. So I think there are economic considerations at play here as well, around things like the expense of proper PPE for workers. I think there's been an impulse to make the model of disease transmission in hospitals, in particular, fit existing resources. It's unacceptable to have this be an aerosol transmitted disease when you have dozens of patients with this disease and you only have 3 or 4 negative pressure rooms in a hospital. So we've almost needed to fit the data to sort of fit the data to the to our resources, rather than look at resources that respond to the data. A bit of a tail wagging the dog situation. I learned recently about the so-called Semmelweis effect. Some of you may know Ignaz Semmelweis was the physician who realized that hand washing could save lives in hospitals, and there was such a strong reaction against Semmelweis, even though he had the data and could show how much of an impact hand washing had. He was sort of drummed out of town. That's been referred to as the Semmelweis effect. When you challenge experts, often they push back excessively because you're threatening their credibility. And I think we have some of that going on with public health and infectious disease. And lastly, we have some entrenched folks. There's this wonderful aphorism from Max Planck that science progresses one funeral at a time, because you have folks who are entrenched and don't want to acknowledge that they've been wrong. And I think the difficulty we've had doing better on COVID is some combination of all of these elements. And we can go over to the Q&A, I guess.
Wonderful. Thanks, David. And just before we move to Alec for the questions, I do want to also thank a couple of people Simon's here too. Great. Kevin is here. Kevin Hedges is the one who got in contact with David to have him speak today. So I didn't know that he would make it from vacation, and he's been integral with our COVID response, and he's so appreciated. So welcome, Kevin. And I also wanted to thank Andriane Chenier, who is here as well. Hello, Andriane. Andriane is part of our LAC and on our board of directors. She obtained her PhD in biomolecular sciences at Laurentian and worked as CUPE Health and Safety representative for 10 years. So she's director on boards of the Public Services Health and Safety Association, the Institute for Work and Health, and of course OCAL, and was very integral in today's putting today's program together with Alec and I and Kevin and our whole COVID response team, Val, Patricia, and everyone. So she's a labor co-chair for the Ministry of Labor Section 21 Committee for Healthcare, Andrian, and a Senate appointee on the Lawrence University Committee. Andrian has lived in Hanmer for 14 years, and she wants to take all her knowledge and skills, experience, and put it to work for the people of Nickelville. So she's running there. So she wanted to say hi, and please put some questions in the chat, Andrian. I'll try to find yours that you submitted before joining us. So we'll leave our video on for our panelists and then maybe take them off. But I'm going to take mine off now and let them address questions. So over to you, Alec.